after that review.
Yeah, we'll go probably, I was just gonna go in the chapel. Usually pretty quiet, and so we can shut the doors in there because it's not like we're in.
Fair makeup.
Yeah, I know. That got cut out of the budget. Well, I was just like, easy to quick glance down. Like it.
Spelled my name wrong.
Shut up. Tell me, I did. I was like, that was a quick this
We'll
morning.
need you to use this microphone, and then when you're done, when you're done with this, and Mike starts answering the first question, just kind of walk up here and hand the mic to Kelly, and then she'll do the rest.
So you're gonna just come in and hand it over, okay?
So you're gonna ask the first question.
Oh,
though, so
I'm
we don't
asking
have
the
the
first.
yeah. So it's
Okay.
not this awkward like
Right.
pause.
Like rotate like this and ask him?
Or just you can scoot.
Yeah, you can
otherwise-
turn. Yeah, you can turn around because we'll
Okay.
take the tighter camera. So you
Yeah,
can
on
turn
him.
around.
So,
Okay,
yeah.
gotcha.
Yeah,
Got it.
if you just want to sort of like this, it'd probably be good.
Just do it like this?
yeah,
Okay.
just like that.
If you're gonna,
If you're gonna look at a camera, it's the one on the right there with the red.
that's the
cord.
close up.
This is the wide camera where everybody's on.
Is this on?
It's on into the camera.
Oh, okay. Can we tell how loud it is? Is that a good
What?
volume? Okay.
It doesn't. I mean, just for the audience here, the studio audience, Doris and Doug and Liz.
Yeah, we got some people to
Yes.
talk to. That's nice. Thank you. Appreciate that. It's more fun than an empty seat.
Are we going to, when we do speak, we'll pop our mask down and speak? Speakers can.
Oh,
Either way, but on.
so should I do that then?
Can you hear them okay with the mask on, or should they pull down their mask when they're?
We can do it. We can do either one. You can hear better with the mask off, but whatever you're comfortable with.
I think CNMDH allows speakers. Off for speaking.
Okay.
They're not on a medical.
You're putting me on the spot, Mike. I don't know the
We were
fine print on
technically
that.
Well, that was one of the questions for you.
You better- So go with this then. Okay.
Go with
In
the
the
mask on.
hospital, it's hard to take it off.
All right. I want to represent properly.
Maybe
So.
mention that we're wearing our masks because we're in a medical facility.
Yeah, you know, we're
Yeah, it
spaced
might
out
be,
and.
it might be a good call out to explain why you either are or aren't wearing it.
Yeah.
Do you want me to do that on the front end, or do you want one of these folks?
One of those folks is probably
The experts, yeah, not
We
the
have a couple
not the
minutes.
goofball talking. Yeah.
We can do a test run if you want. We have a couple minutes.
Oh, testing,
Do a-
testing.
Do a welcome test.
Oh yeah.
Just a-
Thank you so much for joining us today. This is funny, by the way.
What?
It is funny to have. I'll try it again. Thank you so much for joining us today. We are delighted to have a panel of Ridgeview experts with us to provide some insights into what's been happening at Ridgeview the last year, as well as a sneak peek as to some new initiatives as we come out of the COVID-19 pandemic. And then I'll do. Is that all right?
And then.
Since we don't have super, say who you are at the very top.
Oh, introduce myself.
Yeah.
That's a good idea.
Yeah.
John Crow, thank you so much for joining us today. Yeah.
So then, so John, you're going to be the beginning of the whole thing. So begin it like you would a conversation. Hi, I'm John.
Gotcha. Good. All right. Sounds good to me. You think after all this year of Zooming and I'd be better at this, but I'm not. So.
At least you're wearing pants.
Yes. The start.
We didn't fit it at the dump.
1 minute. We have like the.
1 minute.
Oh,
1 minute.
done.
1 minute. 1 minute.
The big green light, red
Yeah.
green light.
Yeah. We'll give you
Okay.
tell you we have water for everybody. Does anybody need a water up here?
They drink them all.
You guys need water? Go grab some.
Yeah.
I'm good too. I'm
You're
good.
good?
I got one here.
Okay.
Okay.
I can go hours without drinking.
One of your superpowers.
That's right. 30 seconds.
Okay.
30 seconds.
My wife's a company example. I read today, camels can drink 30 gallons of water at a time. 30 gallons.
10, 9 seconds.
8, 7, 6, 5, 4, 3, 2, 1.
Good morning. I'm John Crow, chair of the Ridgeview Foundation. Thank you so much for joining us today. We are delighted to have a panel of Ridgeview experts with us to provide some insights into what's been happening at Ridgeview this past year, as well as a sneak peek into some new initiatives as we come out of the COVID-19 pandemic. With us today, we are joined by Ridgeview Chief of Staff, Dr. Todd Elfman, Ridgeview President and CEO, Mike Phelps, Ridgeview Chief Nursing Officer, Elaine Aaron, and Ridgeview VP of Medical Affairs, Dr. Matt Harrell. Ridgeview Foundation Director Kelly Milady will be moderating today's discussion. But without further ado, let's get started. I'll start with the first question, Mike. What impact did the decrease in patient volumes due to COVID-19 have on Ridgeview financially? And are patient care volumes returning to pre-COVID levels?
Well, thank you, John, and hello, everybody. We are wearing masks today because we're in a healthcare facility, so please bear with us as we try and communicate through these. Absolutely, COVID had a major impact on the industry as well as Ridgeview. Whether you're a hospital, healthcare system, or a clinic, anybody in the healthcare environment had a challenging year this year. Ridgeview is no different than that. The beauty of what we've learned in 2020 is that we've had a strong balance sheet, and thanks to strong investments, we've come out of 2020 in a good position for 2021. Patient care volumes are still a little less than normal years would be, but they are coming back, and we're actually finding different ways to take care of patients, whether it's using telemedicine or video visits in order to augment normal care volumes. So we feel like we're in a good position for 2021.
Dr. Elfman, when MPH halted the elective procedures for a period of time last year, what happened to all the patients in need of immediate surgical intervention? And what impact did that halt of procedures have on your team?
I think that the biggest thing that came out of COVID was, what's an elective procedure? As a surgeon, we call it elective procedure, a procedure that doesn't have to be done that day or the next day. But in reality, a lot of what we consider elective truly aren't elective. So we really had to kind of stratify our patients as to what was considered an elective procedure, what was considered an urgent procedure. We were fortunate at Ridgeview that we had the capacity to continue to perform some procedures, so anything emergent was still done, and anything urgent we would carry through with a review by the chief of staff, the head of anesthesia, and the head of surgery to determine whether that could be done or not. Overall, a lot of things did get put off, particularly a lot of orthopedic cases. For me as a general surgeon, we put off a fair amount of elective cases, and I kept a list of all those patients who I would see in clinic, which was also very limited. But then once things opened up, we had our callback list, I called mine. And we've since gone through the callback list and have everybody back up to speed and have taken care of most of those patients. Interestingly, we're still seeing some patients who are still coming out of the woodwork after COVID with their colonoscopies that should have been done a year and a half ago. I just did one about a week ago on a young woman who was there for her screening colonoscopy at age 51 when she should have had it at 50. She was fine, thankfully, but she actually even said to me, with all this COVID, I just didn't want to come in. So we're still seeing patients return to the system.
Elaine, tell us about the process in which you mobilize direct patient care staff to prepare for COVID, and how did they respond?
Sure. Well, first I want to thank our staff. We have a tremendous staff here. In spite of fears of their own personal health scare, risk coming into a hospital where we were seeing many COVID patients at the time, or fear of bringing it home to their families, they showed up. They showed up every day. So kudos. Some of the tactics that we used, we did use some incentives. So we were offering increased hours for anyone who would take it. We were using call shifts, so we typically don't have a nurse on call for all the different units. We did have call shifts, so we could call them in. We really assessed all our resources, so we were looking at RNs, ED techs, any of the direct care, and really looked at their skill set and how we could deploy them differently. We looked at different models of nursing in case we had to go that route, if we had this surge. But we were able to really respond, mobilize, and manage very well during this.
Dr. Harold, having the Norman and Ann Hoffman Emergency Center fully operational during COVID was good fortune. How much of a game changer was that for the ED staff and patients?
I would say it was a minor miracle rather than good fortune. So I still work in the emergency department. I can't thank the foundation and the Hoffman family enough for their commitment to that department, because it literally changed our ability to care for people during the pandemic. Even when volumes were low initially, uh, what COVID did for us was it changed how we needed to triage and evaluate people initially, and then it led to this delay in, well, where do we go next? And so that department gave us privacy, safety, the ability to close rooms, and then a level of comfort that we hadn't had in our previous department. So if I, for example, needed an extended evaluation, or I needed to wait for a bed in the metro if we didn't have a bed, we could provide a level of service that was equivalent to an inpatient room in our emergency department. And so it really opened the door to different opportunities to care for people that we didn't have before. We use all of the spaces, you know, very effectively, from triage to our standard patient rooms to our critical care space. And then unfortunately, our mental health space has been heavily utilized since the start of the pandemic, because we've seen a significant increase in mental health and substance abuse cases. And so we've used that space very, very effectively too. So it's been a game changer for sure.
Are you still seeing COVID patients in the emergency room regularly? Is it still?
We are. So I kind of describe the spot that we're in as kind of the slow burn. So we saw, you know, initially at the start of the pandemic, we prepared for this surge of patients, and then the patients weren't there. And so we actually took that first few weeks where we expected a surge to lay the framework for what we were going to do for the year, no matter what happened. And it was exceptionally effective for us as an organization, and it paid dividends this fall, because this fall we started to see a significant increase in patients. We went from a few patients a day with COVID in the hospital to about 30 patients a day, or, you know, basically a third of our operating beds, COVID patients. And thankfully that's calmed down, but we're still seeing, you know, right now about 8 to 10 or so COVID patients inpatient a day, and about twice that volume in the outpatient setting in the emergency departments.
Any other comments on COVID in the patient care setting that you wanted to talk about before we switch gears to vaccines?
I'd just add on the one of the things that you know, has been one of our initiatives is to increase the level of acuity that we're taking care of on this campus. And that's one of the great opportunities of the pandemic for us, is that it forced our hand a little bit, because it changed how healthcare organizations across the metro had to care for patients. And it inspired us to figure out a way pretty rapidly to maintain a higher level of acuity in our own facility. And then spread that, so that meant that in our critical access hospitals, we were increasing the level of acuity that we were able to care for there. And it really helped all of us, you know, do something that we strategically wanted to get to an endpoint. It helped us get there faster than we otherwise would have.
Mike, I know Ridgeview has partnered with Carver County to administer COVID vaccines. Are there plans to help with other surrounding counties to run similar vaccination clinics? Will we use the semi-trailer for emergency response mobile clinic services?
Short answer is yes. So yeah, in fact, we did partner with Carver County to do a number of different things. You know, when the state started to, the Minnesota Department of Health started to talk to healthcare organizations about performing vaccinations on communities, you know, there wasn't a clear delineation between the healthcare provider industry and the public health division, who has their desire and their demand should be around, you know, vaccinating the public. Well, we really came together around that and tried to think of, you know, how can we best utilize the assets that we have. Ridgeview used our depth in staffing and nursing care to be able to deliver those vaccines in a partnership with Carver County. As well, we did a lot of vaccination on our own outside of that partnership. And in fact, I think the last number I just saw this week was we've provided almost 50,000 doses to the community through Ridgeview. So amazing work by our team, and some of that was in partnership with Carver County, but we've partnered with Wright County, with other counties' public health divisions. We've been in schools vaccinating kids who are 16 and older, and we've also been in employers vaccinating employer groups as they've invited us in and had that demand. So I think we've found almost, and I should say, our clinics have vaccinated, patients that were attributed to Ridgeview as their primary care group as well. And going forward with a little bit of decline in demand, we'll probably move away from that mass vaccination kind of program into vaccinating folks through our clinic system.
Great. Dr. Harrell, there are many skeptics of the vaccine. Should individuals be concerned? Short and long-term side effects?
So I think this is a really important topic. And I think it's important to make the differentiation between vaccine hesitancy or skepticism versus kind of the anti-vaxxer kind of thing. And so the anti-vaxxer movement, those are generally people who would never consider getting a vaccine. And that's not most of what we're seeing with the general population in COVID. That's around 1 to 2% of the population. But there is still a sentiment of concern about the vaccine, which I think early on was entirely reasonable. These vaccines are fascinating technology, but they're new. It's novel technology. So we didn't know if there was going to be, concerns that would develop after more than, the 40,000 people in the initial studies, for example. But thankfully, I think most of those concerns have been addressed because we're at about the 250 million dose mark. And generally speaking, for the vaccines we're delivering, there have not been significant, side effects or harmful side effects. Everybody gets side effects almost to some degree, right? Whether you get a headache or a sore arm or fever, and that's to be expected. That's a healthy immune response. That's a sign that the vaccine is working. But there haven't been many concerning side effects, so that's been very reassuring.
Did Ridgeview administer the Johnson & Johnson? Because that was one that was definitely in the media.
Yeah, so the concern about the J&J vaccine or the Janssen vaccine came up, and it was a concern that was raised early in their studies that there could be potential. Some people, when they develop their inflammatory response, it triggers this excessive clotting potential. And Ridgeview did not distribute that vaccine, and it was a very limited subset of population that developed it, so younger people, and it was 6 known cases out of about 6.8 million administered. So if you're one of those 6, it's a very real issue, obviously. But if you consider the risk versus benefit, we know the complications of COVID, we know the risk of serious hospitalization, death, or long-term side effects from COVID, it's far greater than 6 and 6.8 million. So even that calculated risk would probably be worthwhile for a vaccine.
For clarity, if I may just jump in, we didn't choose not to give it because of that risk. The J&J obviously offers, some benefits to a certain population. For us, we had pharmacists here who could mix the Pfizer. We had a process down for both Pfizer and Moderna. So introducing a third vaccine with handling requirements that were different were not efficient for our event center. So it wasn't over concern that, the Janssen vaccine had this effect. Because we would encourage anyone to be vaccinated, whatever vaccine you can get.
Yeah, that's a great point.
Good point. Elaine, the media has addressed multiple strains of the virus now. Tell us about what Ridgeview has seen in recent weeks.
Sure.
The current testing options. Do they test for all strains?
Sure. So what we're seeing in the state, right, and across the country are these variants. So the most common that we've heard about in the news is the B117, which is the UK. There's already different variants. There's Brazil, there's South Africa, and now India. If you're familiar with the virus, it will continue to morph. We will continue to see variants of this virus, the COVID virus. To do the type of testing to identify what the variant is, requires high-tech equipment. It is typically, it's genomic sequencing is what it is called, and that is typically done in a high-tech, either public health or research type facility. So no, we do not. We rely on Minnesota Department of Health to advise us of that, and they do a sampling. So that's how they're identifying what's in the state. What we've been seeing, though, is interesting, is a shift in our patient population for inpatient, so younger. So perhaps that's contributed to the focus was on the 65 and above getting their vaccines. So we're seeing less of that population, more of the 20 to 59 in the hospital. So just kind of an interesting shift.
Is that 29 to 59 that are inpatient having the severe complications that we saw earlier in the pandemic?
Some. So again, everyone's experience is a little bit different. It's been a very interesting phenomena, I think, with COVID, to see who gets struck how, right? We have seen a few very sick. I think in the older population, it was a little bit more difficult because of the comorbidities. So, that really caused additional, intensive type of care.
Dr. Elfman, can a person who's vaccinated spread COVID?
I think the short answer is yes. But that's the great moving target here, isn't it? Is how much does the vaccination help in preventing this disease process? There's a term out there called mucosal immunity, and that's what we don't think that the vaccine will create a mucosal immunity. So even if you had the vaccine, you could still harbor the virus particles in your mucosa within your nasal passages in your mouth. So the reality is that, yeah, they can.
When and how can vaccinated persons gather and not wear a mask?
And that's changing all the time. I mean, we're basing most of our guidelines on what the CDC and the Minnesota Department of Health, has to say. They just reduced restrictions now, so vaccinated people can gather in groups indoors without masks and without socially distancing, which is great. Going back to the first question, can someone who's been vaccinated shed particles? Yes, but they're probably not going to get someone else who's vaccinated sick. And so this is how we open up, and that's why we again really get people vaccinated, get to that herd immunity, 70%, 80%, whatever that number is. We're getting closer, and the closer we get, the more more likely we can return to more normal activities.
What is the current rate of herd immunity in Minnesota? Does anyone know?
When I looked last night, I believe it was at 59%, and that means one or a complete series, right? So some vaccination.
Does it also include those that have already had the virus, or is that not considered in herd immunity?
No, that's not in herd immunity.
Yeah, and that's a separate number.
Yeah.
So we include those who have had it and those who have been vaccinated in the kind of herd immunity discussion. But it's interesting when they've started to study the level of immune response to having had the virus itself or being vaccinated. Even if you've had it, you have an enhanced immune response with vaccination. So even people who've had it, my folks had it early on, I still said, let's get you vaccinated because your immune response you're better protected against the virus and any strain of the virus with a vaccination, even after you've had the infection itself.
And I just said to add, it's not insignificant. It's a 7 to 10-fold increase in your immunity with the vaccine versus having COVID alone. So it's a big deal.
Yeah.
How long can the current vaccination protect a person? We hear about needing potentially a booster. So, Dr. Held, do you want to touch base on that?
Sure. So there's not an immediate answer. It's kind of a TBD. What we know from the initial studies is that at least 6 months, and that's why you'll hear in the media that it only lasts 6 months. Well, it was studied to 6 months initially. There are ongoing studies, and so data is coming out all the time from patients who have now been vaccinated for beyond 6 months. And so we know, based on just the way the immune system works, that over time your immunity starts to decline. What we don't know is how steep the curve is. And the most important thing is, even if it lasted some number of months, it's still worth getting because these vaccines happen to be so effective that you're starting with the bar so high that you have a longer time to decrease in immunity over months before you would become at risk to get seriously ill again. And so that's, I think, the key takeaway. There will likely be a booster of some type required for these vaccines, and it may come in the same type of vaccine. If you were vaccinated with Pfizer, you would get a booster with Pfizer sometime later in the year. There's a lot of interesting science going on with, trying to booster against specific variants, for example, and those studies are ongoing. So I think people continue to hear more about boosters over the next few months. And we'll be ready to respond whenever the State Department of Health gives us access to boosters.
Elaine, if vaccines are approved for children, are there any significant concerns about how effective they will be?
Sure. So pediatric population is a little bit different. And what we know from experiences, especially in the adolescent population, you see a lot more anxiety about the immunization, and they tend to be fainters. So you have to be prepared for that. But as far as the side effects, same side effects, that you're seeing in the adult population. It's your sore arm, your fever, some body aches, etc. So I think the concern is really more around the operational part of getting them vaccinated. Having their parent, a parent or guardian, really has to accompany them, and anticipating that you're going to spend a little bit more time with them than the adult population.
Will Ridgeview administer vaccines to pediatric patients?
We are in discussions right now and working with our pediatric partners as well. So that's what we're exploring currently.
Mike, what are the impacts of the new CDC mask recommendations, and will Ridgeview be changing their requirements?
Well, I'll probably defer some to my clinical colleagues next to me here on both sides of me, who are probably better prepared to answer that. But and with the governor just announcing today, I think that as July 1st, he's going to potentially end the mask mandate for Minnesota, or earlier if we hit 70% of the population being vaccinated. My goal as the CEO of a healthcare organization, we have to live to different standards, and as an organization who's probably has a higher potential for exposure by having positive COVID patients in our environment, we'll likely be masking at different time frames and different levels than the public might be advised by CDC. So we'll look to Minnesota Department of Health and the guidance from our clinical partners to gauge that. But I suspect that masks won't be going away too soon in healthcare organizations to some level. So, any other?
I would agree with you, Mike. When you look at, we have to protect our patients, right, from us. So that we deal with typically immunocompromised. I mean, many people are. So in our interactions with them, we will be extra cautious. So I would imagine that MDH, that's our guidance, Minnesota Department of Health, we would have to follow their lead when they make changes for healthcare workers.
It's interesting that we get a lot of questions as physicians from our nursing staff particularly. Are we going to have to wear masks forever? And honestly, we don't know. We're hoping not to. And again, that magic herd immunity time frame, if we get there, we can maybe shed some of these masks. There's clearly a mask fatigue and a COVID fatigue out there in the general population, as well as in the medical industry. So,
yeah, how is morale at the organization?
In general, it's been very good and very strong. We were talking about this a little earlier today, and as chief of staff, I often will stop people that aren't expecting it, and just to have a little conversation and ask them how are things going, how are you doing. I get the sense that it's very strong amongst Ridgeview's community here. In the early parts of COVID last spring and summer, everyone was a little bit kind of weary. But even then, I just felt there was a strong presence of we're out to do the best for the community. And one of the ways that we can do that is to show a good example and kind of have some confidence that we're doing the right things. As the pandemic's gone on and we've opened up and we're getting back to more normal, whatever that is, I think morale's been pretty good. maybe you can sense differences in the emergency department, but in the general, the staff in the hospital has been pretty good.
Yeah, I would probably just add that 2020 was a grind, right? And we're but truly, I think our staff has risen to the challenge of continue to try and care for people in our community. I mean, that's what we are here for as a not-for-profit health system. We have no other mission other than to care for our community. So, people that work in healthcare have those strong values that, in a crisis, we respond. And, our staff, our physicians, our nurses, and all of our healthcare workers across the system really did respond well and amazingly to that. And I think the vaccine, when it came along, provided a little hope.
Yes.
Right? I mean, it did give us a little bit of positive lift in terms of bringing that, healing kind of feeling back into our organization. And at the same time, we know, little blips like the past month where there has been an increase in volume, sometimes provide, a little consternation, right? Or a little concern that we're not done with this thing. And we don't know when we'll be done with this. It may end up being like the flu, where it's something that's around every year for a period of time, and we have to get boosters, and we have to, respond, and people will be sick from the flu, they'll be sick from COVID, and so, we've got our ear, to the ground and nose to the grindstone, and any other analogy you want to use about trying to predict the future, of how we respond to COVID, and that's from, my role to everybody working in environmental services. How are we cleaning rooms? So it's organization-wide, both the excitement, the fatigue, and the concern about what COVID's going to mean to us going forward.
Here's one for either Elaine, Dr. Harold. Visitor restrictions have been frustrating, potentially for some patient families. So
Yes,
when do you see
yes.
those being lifted and going back to pre-COVID?
Again, pre-COVID, I'm not sure of, right? Because again, I feel, I'll speak for me, but I know organizationally, we need to protect our patients, right? That's the goal, and that was the goal behind these restrictions, is the more bodies you had going through the floor, the bigger risk to the overall population in this house. So it was very, very frustrating. It was extremely hard. It was heartbreaking. I can tell you I took many, many of those calls, as did Dr. Harold, with families begging to come in, and we tried to make as many exceptions as we could and be as compassionate. But when we had 33 out of our 60-something adult med-surg beds filled with COVID and sick COVID, you need to think each entry into that patient's room and exit, again, is an exposure, right? They're coming in and out. We're trained. We're trained to put on the PPE. We're trained on infection control. They are not. So when we're doing our just-in-time 2-minute, this is the guard you got to put on before you enter the room, we know it's increased risk. So hope we're getting back. We've loosened a little bit. We have more exceptions, and we continue, to loosen those restrictions. But we try to stay to the Twin Cities, right? So we look at our community, but also what is this broader impact that we have. So
I would probably just add to that. We talk a lot about it in orientation. There's in a community health system like Ridgeview, there's not the phenomenon of 6 degrees of separation between, you knowing a stranger. There's probably 2 or 3 degrees of separation between knowing the people that we're caring for in this community. And so trying to convey that our policies are really around keeping you safe. And so looking for some understanding during a pandemic was really a challenge for us to convey, to our friends and family that had loved ones in our facility. But again, to Elaine's point, it was about keeping them safe, as much as anything. And we did have compassionate care policies. Yes. Where if somebody was, doctors and nurses know when people are not going to make it usually. And so when those scenarios were about, we certainly let families in and had people there appropriate to be able to say their goodbyes in those compassionate settings. But it was a big challenge, and kudos to Elaine and our nursing staff who had to amend some of their policies for visitation.
And I'd like to add to that too, just to commend our entire staff, but particularly the nursing staff. You know, as a physician who's in the hospital every day, seeing patients every day, the patients really appreciated how the nursing staff made them their family, knowing that their family couldn't be there. And I'm not sure you get that in a bigger metro hospital. I mean, this is one of the key one of the main things that a place like Ridgeview can offer a patient and their family when they can visit. But if their families can't, then we become their family, and it means a lot to the patients. And I hear comments every day about what great care they had here at Ridgeview, and I just would like to commend the nursing staff for that.
Absolutely. And Kelly, just one more thing is we also did a lot virtually. So we did deploy iPads again to help engage the family, and our nurses would go in and connect with family members so that the patient and family member could stay connected.
Great. Elaine, you mentioned PPE. Was Ridgeview ever short? You know, you saw again in the media these shortages. Were there times when we were short on PPE, and how did that impact?
Yeah. Not short. So we were able to supply what our staff needed. We did deploy some strategies, preservation strategies, to ensure that we had it for the long run, right? So I will say that, but we were very fortunate and we could provide what our staff needed, and those continue to morph now as standards change.
Dr. Elfman, anything to add with regards to the surgical planning? When is it back to kind of the old way of thinking, or is it still kind of a slower process to get back to full capacity?
I think it's pretty close to being back to full capacity. We have some scares now and again when the hospital starts to get full. We kind of hear rumblings about we don't have beds for these elective cases next week, and but we haven't had to restrict yet. Some of the metro hospitals have done that in especially this last month with the surges that have happened. We have not, but it's always out there on the horizon. I mean, we could get a fourth surge. Who knows? So we're prepared for that. In the initial time frame when things were shut down a little bit, we did some pretty creative maneuvers with our surgeries to really help guide through it. And I think we could go back to some of those if we needed to. We had some of our same-day surgery nurses staying overnight and keeping patients overnight in same-day surgery, so they didn't have to occupy a bed in the hospital. So there's some creativity that can be used if we get to that point, but I'm hoping we don't go back to that at all. So
I think we all are.
Yeah, exactly.
Anything else regarding COVID? Otherwise, I was going to switch gear to something a little bit lighter, more exciting, positive. Anything else? So switching gears, Matt touched base on a little bit, but Mike, we've heard that Ridgeview will be providing a higher level of care, higher acuity patients. Like, what type of patient populations would be impacted?
Yeah. Well, certainly since COVID has slowed down, we've taken some time to really dust off our strategic plan and not be in such a reactionary mode as to what we're doing operationally, but really looking forward to what should Ridgeview continuing to be doing in the communities to make sure that we're set up for long-term success. So as Dr. Harold mentioned, we learned a lot about our capabilities clinically during COVID, and so we've taken some of those learnings and are really now thinking about potentially expanding our cardiovascular cath lab to 5 days a week, elevating our neuro stroke capabilities through some partnerships. Elaine and her staff, along with Dr. Harold, are working with Children's of Minnesota to talk about neonatal intensive care unit, taking lower gestation and lower birth weight babies, so we're able to keep parents and kids closer to home. Pediatric patients in general, and then also senior care, looking at how can we tailor some concierge type services around seniors in our community. So there are a plethora of things that are going on out there that we are looking at, and all of those will raise the acuity and also challenge us around capacity for beds. So we'll also be looking at what does Ridgeview need to look like in the future going forward.
Elaine, Mike mentioned the neonatal care unit regarding pediatrics. Is there anything else in the horizon for pediatrics? It's something we hear a lot about. Young families in the community. Can my child be closer to home at a place like Ridgeview?
Sure. So our vision is really around women and children's overall, right? So it starts with perinatology, the maternal fetal medicine. And so we are improving our services there, access in particular, to that service. OBs will be able to deliver once I'll start referring to it as an NICU. As our NCU transitions to that, it allows our obstetrical groups to deliver down to 30 weeks here as well. So we have all that support. And then when it comes to pediatric patients, I don't think anything is off the table right now. We're engaged with children's. We had originally planned with the emergency department remodel to have a clinical decision unit and house a lot of our pediatric patients there because they tend to be very short stays. But then came COVID and that changed that. And as we've morphed, we are evaluating that and saying, is that the best place or what should we be doing? And children's is in a different place as well in our discussions and their ability to perhaps offer additional services. So we have a great model at 212 right now with children's where it's a children's ED doc that can see. And so we're looking at how do we expand that? Because when you look around our area, it is a growing community with young families. And so I think we all feel that we're a community hospital, regional, but community, that's who we're dedicated to. And the pediatric population is part of that community that we want to serve moving forward.
Absolutely. On the opposite end of the spectrum, you also touch base on the aging population. So what are we doing to prepare to, take care of this growing aging population?
Yeah. So Dr. Harold can speak to this a little bit as well. We just went through the process. Our application is in to become a geriatric certified emergency department. So that's pretty exciting. And what that involves is additional training as well. There are protocols you have to have in place, certain services you have to have in place. The physicians and other staff have to go through hours of training, for that specific population. And that will tie in again to the floors when you're looking at the inpatient as we increase acuity and who we care for. It's also, again, learning about that population and doing more for that population.
Yeah. To me, the enhanced geriatric programming that we're developing is really just kind of examining the patients who we're already caring for and how can we serve them better. And it really comes down to enhanced care coordination regardless of where they're accessing our system. And so we knew that there were some gaps in the emergency department. When patients would access our emergency department, we didn't have the capacity to connect them with the other services they need as efficiently as maybe we should. And so this certification is going to kind of increase our level of evaluation and provide a little more standardized, coordinated care for those patients, whether they're going home, whether they're going to an assisted living facility in the community, or whether they're staying in the hospital. And then we can extend what we're learning through the certification, extend that through their hospital stay, into the post-acute stay, into the clinic follow-up setting. And so it's just kind of one of those things that makes sense. So we're pretty excited to see it take shape.
I would just add, Ridgeview will be the first health system in the state of Minnesota to have a senior certified emergency department. So we're really proud of that.
This is kind of just a question for all of you. I mean, now that hopefully we're past the biggest surge of COVID, what keeps you up at night? What kind of keeps you thinking about what's next?
Trying to keep Mike happy. I think I don't think that anything's keeping me up at night, but I just really look forward to kind of getting back to more normal function. Interactions with staff and interactions with patients, it's getting closer. And again, it kind of goes back to COVID a little bit, but we're getting closer and closer to functioning like we are trained to function like we're used to, and that's been exciting for us. So hopefully that'll continue. And
maybe not keep you up. Maybe what are you most excited about past this hopefully surge of COVID?
I would say I'm most excited about getting back to face-to-face meetings. You know, Ridgeview prides itself on our culture, you know, and making sure that you matter here, whether you come in as a patient or an employee or a staff member or a colleague of ours. We want to make sure that you feel like you matter here. So getting that face-to-face interaction, being able to see this part of somebody's face eventually would be wonderful. You know, other than that, you know, what keeps me up is that we have so much opportunity as an organization to continue to grow and to continue to improve that we can't do it all at once. So our excitement's going to want us to do it all at once, but we're going to have to work our way through those things and start with higher priorities and get the work done. But it's a great place to be, and it's a great position to be in as an organization to have, you know, so many great things working for us and so many opportunities ahead that it's equally positive and equally keeps me up at night. So.
And actually, similar, I was going to say what not really keeps me up, but it's out of the excitement, is we have some great plans, and I realize it's a strategic plan. So we're talking through the next 5 years, but I want it all done like yesterday. So I struggle with that a little bit.
You
I
don't
wake
like
up.
this last pause
Yeah.
that we had right here for the last year or so?
Exactly. So, but it's all good stuff now, right? And to take the learnings from the last year, because if one thing I think came out of all of this is we certainly learned our strengths and how we can mobilize, pivot. We have a lot of strengths. We recognized our weaknesses, and that gave us opportunity to correct some of those weaknesses. But I think there was a lot of positive that came as a team in our learnings, and I don't want to lose sight of those learnings as well.
I still lose a little sleep. I'll admit it. What keeps me up at night a little bit is just, you know, this isn't quite going away as fast as we had hoped, and the fatigue does wear on people clinically. It's hard work, and it's hard to run with a blister on your heel. And so I worry a little bit that there will be more people who just kind of, you know, can't give all that we expect, because we expect a high level of commitment and engagement. And the fantastic thing about the care we provide is that we are all in, we're invested. And it's hard to keep doing that when you don't have a lot left in the tank. So what worries me is that people will start to feel like they don't have enough and maybe they should get out. Thankfully, we're not seeing that to a serious degree, and I think we have enough people who have kind of weathered the storm and realized, you know what, this is what we're here to do. We're here to serve other people in our community, and I'm going to do it. And I'm pretty optimistic about this organization. I mean, I would take this organization against the field any day of the week and twice on Sunday, because I mean, if you look at, you know, to Todd's comments earlier on the medical staff, we have a mixed medical staff of all sorts of, you know, private physician groups and hospital employee groups, and you would look at it and just be like, oh, it's a mishmash, it's not going to work. And we have probably the highest degree of, you know, collaboration and communication of any medical staff around, and we're providing a level of service that, you know, meets or exceeds any one other organization around us. We have fantastic administration. I mean, or at least okay. But you know, the relationships that we have as clinicians with administration and leadership across all of our organization is second to none. And so I lose a little sleep just making sure that we can get everybody in and maintain everybody's you know, engagement. But I think we have so much to offer that everything's up from here.
Last question here, Mike. What do you want to say to all of the donors that have stuck with Ridgeview for years and years, especially in light of COVID? What can you say to them?
Yeah. Well, I mean, and for those that I've been able to meet through the foundation, hopefully they all know, I mean, because of your work and because of your generosity, you helped us get through COVID. I mean, you know, we can afford to lose money during a calendar year because we have such a strong balance sheet because of the donations and the philanthropy and the energy behind the foundation. You have helped us really succeed and get through 2020 when we may not have in other scenarios. So I would just say, a deep level of gratitude and thanks to you and for your generosity, no matter who and the level of your commitment and relationship with Ridgeview. We love you all, and we thank you all for helping us be the organization that we can be and continue to deliver on caring for the community. So again, thank you from the bottom of my heart and from our team for all the work that you do and the energy that you bring to us.
And sorry, not the last question. We just had one more come through.
Okay.
What's one good thing that came out of COVID? And on the positive note of COVID, not all doom. What's one good thing that you can say came out of COVID?
Yeah. Well, I and it's the theme is probably already there. I think we've really learned who we are, and we've learned our strengths from. Dr. Elfman mentioned it. To have 3 independent physicians gather around as leaders on the medical staff and define what we should be doing as an organization when they have no employment relationship with Ridgeview. They're committed to Ridgeview, and they were helping us decide how to get through this pandemic, and by taking the leadership and making decisions on behalf of the organization. It just brought us all together, and I think made us stronger as an organization and a medical staff, and and with our staff. So I think it's been an event that's brought us together.
Awesome. Any other last comments?
No, I'd just say that the one kind of concept that I think we learned out of COVID was that we learned to think about the most right thing rather than what's the right thing. We always try and do the right thing, but this last 14 months or whatever has caused us to think, all right, what's the most right thing, knowing that we can't do what we want. We can't give everybody everything they want. And it's really hard to figure out what's next, where should we go, how should we get there. That it has changed our thinking, and it's going to help us in so many different ways moving forward. So.
Well, sincere thanks to our expert panel here. We really appreciate you taking the time to join us today, and for all of our viewers, our partners, we're just so grateful for all of you. So thanks so much, and have a great day.
Thank you.
Thank you.
Thanks.
Thank you.